services and patient safety. Justification and optimization are the cornerstones of the radiation protection, and their proper utilization requires competent health professionals. The focus that the Isrrt is placing on justification with this pre-Congress workshop is of greatest importance for the population globally and for individual patients everywhere. We at the Radiation Protection of Patients Unit of the IAEA are very happy to be in collaboration with Isrrt in organizing this workshop, and we hope you take the opportunity to learn from the experience of speakers and to contribute to the discussion on the role of radiographers in the justification process. On behalf of the International Atomic Energy Agency, I convey my best wishes for the success of the Congress and the pre-Congress workshop. Thank you very much.
Thank you, Stuart and Jenya, for setting the scene. We now move to our presentations. The session consists of 2 presentations, after which we will be holding a live panel question and answer session. We encourage you to post questions in the Q&A window available as the session progresses. So now I would like to introduce our first speaker, Dr. Amanda Martin. Dr. Martin is currently lead radiographer at Bolton NHS Foundation Trust and still manages to fit in the reporting of musculoskeletal images. This is a part of her role which she has resolutely refused to give up as she has progressed through her career, which she has involved working within most modalities, academia, and management, but always comes back to plain film imaging. She is passionate about plain film technique and in educating radiographers about the subtleties often missed on images that are not correctly positioned. She holds a fellowship of the College of Radiographers and has contributed to and is writing books within the Clark's series. Amanda's presentation is on authorization versus justification.
Hello, my name is Amanda Martin, and I'm the lead radiographer at the Royal Bolton Hospital, which is in the northwest of England. I've been asked to speak to you about justification and authorization for referrals coming into the radiology department. Just to say, I have no conflict of interest to disclose. So before we can justify or authorize a request, we need to receive that referral. And that can either be in paper format or electronic format, depending on how your organisation works. Some referrers will make use of referral guidelines, whilst others will just use instinct or experience and request the examination that they feel is the correct one for their patient. I'll look at the benefits of referral guidelines and how these can be used to assist us as radiographers in carrying out the correct examination in a timely manner. We are all aware of the importance of making sure that we do the right thing to the right patient at the right time, and that we minimise the radiation dose. This starts off with the justification or authorisation of that incoming referral. But what do justification and authorisation really mean? And what's the difference? I will explain these 2 terms and look at the use of authorisation guidelines and the governance associated with radiographers carrying out justification independently. Let's start by looking at referral guidelines. These help clinicians to decide what the best examination is to do for their patient in order to inform clinical management or to support a suspected diagnosis. They're required by legislation in most countries, and they offer up-to-date evidence-based information on all radiology examinations. Such guidelines help referrers to select the correct modality to refer into, based on gaining the most information using the least radiation, thus reducing the radiation burden to the patient, which is caused by doing the wrong examination. If the wrong examination is requested and inadvertently performed by the radiographer, that then becomes an over-radiation exposure incident. By making sure that the first request made is the correct request, this improves the effectiveness of the imaging department because time's not wasted chasing the clinician to get more information. The patient journey is therefore much improved. The correct examination is done faster, and diagnosis and treatment can start sooner. There are national and international referral guidelines which have been developed, and these outline the most appropriate examination to request for given clinical situations. The European Society of Radiology have published referral guidelines known as iGuide, and the Royal College of Radiology in the United Kingdom have published guidelines known as iRefer. As well as helping clinicians choose the correct radiological examination, they include the cost effectiveness of the examination and a dose indicator. They also go on to recommend alternative imaging and the benefits associated with this imaging. Referral guidelines can be procedure-driven or indication-driven, and both require the input of patient demographics initially. So let's have a look at procedure-driven guidelines. Procedure-driven guidelines are based on the imaging examination being considered. When the clinician sees the patient and decides that they want to request a certain examination or procedure, they then search for the clinical information. So in this case, the CT head with contrast will have been inputted, and the clinical indication of long duration ataxia is also inputted. This will then tell whether the examination that they've requested is appropriate compared to other possible examinations that can be done. Here we can see the CT head with contrast for a patient with long-standing ataxia, and it's less appropriate than an MR head scan without contrast. It goes on to show that radiation dose for the CT scan is higher, obviously, but the CT scan is cheaper than the MR scan. The clinician will then decide which examination they're going to refer the patient in for. Now let's look at indication-driven procedures. So these are guidelines based on the clinical presentation. The clinician inputs the presenting condition, and a suggested list of examinations is shown. And as we can see, the MR scan without contrast is the most appropriate examination. Here we have the Royal College of Radiologists iRefer guidelines for a patient presenting with back pain. This particular patient also has red flag features. These are indications of potential serious pathology and include things like weight loss, systemic illness, fever, or neurological deficit. This guidance lists the possible examinations to be considered and summarises when examinations may be appropriate. This suggests that an MR scan is the investigation of choice, but it also goes on to suggest that plain X-ray or CT may be indicated in certain circumstances. For example, before surgery, a plain X-ray may be done, or if soft tissue biopsy is being done, CT may be beneficial. There are challenges in implementing referral guidelines. Not many clinicians are aware of them as they're not discussed during undergraduate education. They're not readily available. Interestingly, they are free to radiologists who don't particularly use them to refer patients into their own departments, but everybody else has to pay. Those who have access need to be aware of the format of the guidelines. So if it's a paper format, are they using the most up-to-date, or have they used a paper format taken off somebody's bookshelf? And if it's an electronic format or web-based, somebody has to be responsible for the upkeep of that website. It is possible to develop local referral guidelines, but this shouldn't be done in isolation, as they might conflict with specialty guidance. Regardless of which referral guidelines are used, if any, once that referral is received, it needs to be justified. So what is justification? Justification determines if the examination is the appropriate one based on the specific risk-benefit analysis. Will the outcome of the examination affect management? Because if it won't, then it's not the correct examination. Has the examination already been done? Because if it has, then it probably doesn't need doing again. Is this the right time for the examination? An example of this is in the investigation of a child who might be presenting with a sudden onset of limp. If perthese is being considered, then a plain X-ray at initial presentation is probably not going to be beneficial, because the avascular necrosis looked for on that X-ray won't be seen until 10 to 14 days later. In this case, an ultrasound scan would be the better examination of choice at the onset of the limp. And we all know that this is now a non-ionising examination for this child. The role of justification lies with the IRMA practitioner. And in the United Kingdom, regulations changed in 2017, stating that the person justifying an examination had to be entitled to do so. Radiologists, by virtue of the qualifications, are entitled to justify examinations. But if a radiographer wants to do this, they have to have had the appropriate training beyond that of their undergraduate qualification. So just for clarification, an IRMA practitioner is not the same as a practitioner. A practitioner is somebody who practices within a profession, so us radiographers are practitioners. An IRMA practitioner is somebody who's been given entitlement to take responsibility for each exposure to ionising radiation. That entitlement is normally given by the chief executive after appropriate training. It's usually senior radiographers who seek entitlement to justify examinations, and they generally have postgraduate qualifications in, for example, reporting or CT. They may want to justify examinations in order to speed up the patient pathway, as often a radiologist might not be immediately available to answer questions about a referral. They must demonstrate that they understand the diagnostic value of the exposure and that they are able to evaluate techniques which may have less or no radiation to achieve the same outcome. They must also be able to consider the urgency of the examination and conduct a risk-benefit analysis, taking into account the detriment that any exposure may have. To do this, the radiographer needs to know the theory of radiation dose and the fundamentals of radiation physics, so that they can apply this to the radiation protection of the patient. They also need to understand the fundamentals of image acquisition and how dose optimization techniques feed into achieving the highest quality image with the least radiation dose. And finally, they need to have in-depth knowledge of legislation, regulations, and procedures, and the governance associated with these. Practically, and this can be demonstrated by ongoing audits, they need to demonstrate how they can use clinical and radiological information to justify their examination, and how that might impact on the patient pathway if the examination is both justified or rejected. They need to be able to communicate the decision to the referrer and to the patients, and also manage unjustified requests appropriately. It's clear that radiologists or the entitled radiographer cannot be around all of the time to justify requests, so an alternative method is needed. Pre-justification of examinations is done through the production of authorization guidelines. Authorization is the act of giving somebody permission to do something. So the guidelines give a radiographer permission to do an examination. These guidelines should be evidence-based and indicate when an examination can take place and when an examination should be rejected. They should also list, where possible, any alternate examinations or modalities that could be used. So, for example, this is the guideline for an abdominal X-ray. So an abdominal X-ray is justified when the patient presents with obstruction, but isn't justified for a patient who presents with perforation. In this instance, an erect chest X-ray is better. Here are two more examples of chest X-ray requests, and we've done a lot of these in the last few months. We know that a chest X-ray is justified for a patient presenting with a cough, but is it justified for a patient presenting with no respiratory symptoms and uveitis? So some conditions such as this may be included in the authorization guidelines, but let's face it, if we include everything in the authorization guidelines, this document will be getting pretty big. However, the person entitled to justify will know that there is a link between uveitis, which is inflammation in the middle layer of the eye, and the lungs. Up to 30% of patients with sarcoidosis initially present with uveitis, and up to 70% of sarcoidosis patients eventually develop uveitis. Therefore, this request is justified as we're looking for sarcoidosis on the chest X-ray. We all know that clinicians don't put everything on that request card, so it can sometimes be difficult to decide if an examination is justified. And it often requires a little bit of reading between the lines and a lot of extra knowledge. So in conclusion, there are a number of guidelines for referring into radiology services, which are evidence-based and reflective of current practice. But once that referral is received, it needs to be justified by somebody with the appropriate clinical knowledge to allow a risk-benefit analysis based on clinical presentation and imaging history. Authorization guidelines will help with this, but having radiographers entitled to justify requests will help with those requests that don't have much detail and don't fit nicely within the authorization guidelines. This level of clinical knowledge is not taught in depth at undergraduate level, and as such, further education is needed for radiographers to be adequately justifying these examinations. Thank you for listening, and I hope I've been able to outline the differences between justification and authorization and the legislation and governance associated with this.
Thank you, Amanda, for such an informative presentation. I would like to remind you of the panel question and answer session, which would follow our second presentation. So please do continue posting your questions on the Q&A window. Our next speaker is Dr. Kerstin Bach-Lidahl. Dr. Lidahl is a professor of the University of Southeastern Norway. Her field of research is quality and sustainability of healthcare technologies. Kristin is interested in diagnostic imaging from a health services research perspective, as well as from an ethic perspective. Kristin is involved in ongoing PhD and master projects related to the role of radiographers in the referral and justification process, and coordinates a master's course on justification and skill mix in radiology. Kristin's presentation is on the importance of clinical history taking and teamwork.
Hello everyone, my name is Kristin Bach-Lidahl and I'm a professor at the University of Southeastern Norway. Today I will give you a short presentation of the importance of clinical history taking and teamwork. I have no conflict of interest to disclose. Let me start with just reminding you of how clinical information is important for several tasks in the imaging process. It is self-evident that it's hard to determine whether a request is justified when clinical information is insufficient or absent. The radiology professionals depends on this information for selecting the right modality and protocol and for safe use of contrast media. The clinical information is also needed to prioritize the patient reasonably, and it's used for appropriate patient positioning, selection of projections, and moreover. Finally, sufficient clinical history has shown to improve interpretation accuracy and clinical relevance of the radiology report. Despite these facts, insufficient clinical history in referrals is a common problem, reported from hospitals in many countries, as indicated in this list. Incomplete clinical information in referral are reported at a rate of 32% for general X-ray examinations from Australia and 48% for CT and MRI from Poland. In both these studies, missing clinical information was reported the main reason for unjustified examinations. A bit lower rate is reported from Portugal, with incomplete clinical information in 15% of CT and ultrasound examination. From UK, 70% of various examinations was reported to lack a clinical question. The two final studies reported the insufficiency of clinical history and clinical questions separately, in both cases on CT requests. From UK, where 22% had insufficient clinical information and 5% insufficient clinical questions. The corresponding numbers reported from South Africa were as high as 71 and 22%. The persistence of this problem indicates that it's unrealistic to expect adequate clinical history provided by all referring clinicians. That is why clinical history taking can be a task for radiographers. In many cases of ordinary practice, the radiographers are required to seek additional information from the patient, for instance, in order to clarify if the patient has capacity to cooperate in the examination. This may include eliciting the clinical history verbally, physical examination, or visual observation. However, the assessment of patient is usually performed tacitly and in an ad hoc manner. The clinical data are gathered randomly and rarely documented and shared within the healthcare team. The quality of practice and teamwork calls for a more formal approach. I will now show you two studies who have tested such formal approaches. The first example is an early small pilot study from Australia. They used a clinical template form with 5 areas: area and type of symptoms, current and past history, psychosocial and occupational history, and a field for additional relevant patient information. 6 radiographers completed the templates after receiving pre-trial briefing on how to use the template, methods for interviewing, and the transfer of the complete template to the radiologist. A sample of 40 patients for general radiography were randomly selected, and data was collected from focus group interviews with radiographers and a short questionnaire for the radiologist. They found that clinical history template form aided in radiographic clinical decision-making in 38% of the cases and caused a change in the procedure for 18% of the cases. The radiographer reported it aided in establishing a strong radiographer-patient relationship, and the radiologist reported it contributed to sustainable diagnosis. The disadvantage was that it slowed down the examination and reporting slightly. The second, more recent study is from a children's hospital in Ohio, United States, where the radiographers used a what, when, where model for completing the clinical history, eliciting the nature of symptoms, description of injury, or course of clinical concern, the duration of symptoms, or time of injury and the focal site of pain or abnormality, if applicable. 84 radiography technologists received systematic training, coaching, and feedback throughout all 4 phases of the project, which was launch, support, transition to sustainability, and maintenance. During the first 3 phases, 3,400 studies was audited and the clinical history analyzed. In addition, 33 radiologists were surveyed after 4 months. The outcome was an increase in appropriate clinical histories from 38 to 92% over a period of 15 weeks, as you can see from this figure. They also managed to maintain the level of performance for 7 months. The radiologists reported that the history had moderately or markedly improved their interpretation on a regular or frequent basis, and were very satisfied with the histories provided. In summary, formal clinical history taking by radiographers shared in the healthcare team can improve clinical decision-making, appropriateness of examination, and the radiology report. Thank you for your attention.
Thank you, Dr. Liddell, for such an interesting presentation. Now it is time for our panel discussion and panel question and answer session. We had a number of questions coming in from the chat, and we can start with the first question, which I think is addressed to Amanda. How would you recommend a radiographer to proceed if he or she disagrees with the radiologist on a specific examination is justified or not?
Okay, yes, so I can answer that question, I think. So it's a very good one, and we know that radiographers and radiologists often disagree on whether an examination is justified or not. The question, as it is, the radiologist has the entitlement to justify or reject that examination. If it's a radiographer who has not been given entitlement to justify. So in answer to the question, you would have to go with what the radiologist said. You couldn't overrule the radiologist. If it was a radiographer who has been given entitlement to justify, then probably they wouldn't be asking the radiologist anyway, so the examination could go ahead. I hope that answers the question.
Yeah, okay. I have a question for Kirsten. You mentioned a number of studies where it was shown that there was incomplete, incorrect, or missing clinical information. So if a practitioner, whether he's a radiologist or a radiographer, is in a situation when there is incomplete information, what are your suggestions of how this could go about?
Yes, like I said in the presentation, one way is obviously to seek more information from the patient. And I think that is an underestimated task that the radiographers could go on developing how to do this in a systematic manner. But of course, it's also an option that they contact the referring physician or consult the radiologist if they can gain some more information about whether or not or what kind of examination is the most appropriate in the specific case. So there are many options for the radiologist, and we have seen some smaller interview studies where the radiologists use a lot of sources in these cases when the referral information is insufficient. So there are many options.
Thank you, Kristen, for your answer. Louise, I don't know whether you have any questions from your end.
Yeah, Frank, there's another question that's come in related to Amanda's presentation, and it's just asking about the responsibility for justification and the requirement for further education, whether it's, and surely graduates are able to justify for projection radiography, but is it that for other modalities there needs to be further education?
Yeah, so before, certainly in the UK, before the regulations changed, it wasn't very clear cut who could justify the examinations. It was seen to be the radiologist, but the regulations then indicated that a radiographer who is then justifying needs to have the appropriate education to do that. Undergraduate education, it's jam-packed with being a radiographer. There isn't enough time, I don't think, to include everything that then needs to be included for every examination. The risk benefit of that, we all understand the risk of radiation and we can apply that. And the underlying medical knowledge that's required to justify some of these examinations. So the example I gave of uveitis, as a reporting radiographer, I know that link, but I'm not sure that many undergraduate radiographers would understand that link. So I think that from a regulation point of view, there's a requirement for further education, but from a practical point of view, there is a requirement for further education to prevent requests being rejected inappropriately, but also to prevent examinations being done inappropriately. Okay. I don't know what Kristen's nodding, so I'm presuming you agree with that.
Yes. Can I just follow on actually just with that just for 1 minute, Amanda, because another question just came in and it asks if radiographers are working single-handedly on call, then how can they cope with this situation?
So your authorization guidelines are the permission to justify a request given by the person who's signed off those authorization guidelines. And you do try to put in those guidelines as much as you possibly can. But there are occasions when it's not there. So we're always coming across specific conditions that we think, yes, we didn't include that in our guidelines, so we'll put it in. And that will always be the case. But as Kristen said, you can always go back to the referrer and say, do you know what? I'm not sure why you want a chest x-ray because this patient's got a problem with their eyes. And the clinician then can say, well, actually, I'm looking for, right, okay, that justifies the examination now. So it's a combination of using those authorization guidelines as well as seeking further clinical information from the referrers. Because the referrers, I think, sometimes presume that we know everything and we don't really.
Can I just say something about this? Referral guidelines are guidelines.
Yes.
So how binding are they actually?
You're right, they are guidelines. They're not binding. They are there to assist. The authorization, we have our own referral guidelines where I work. We've generated our own based on our authorization guidelines to assist in the correct referral because we were having a lot of rejected requests. That were then coming back with better information. And this goes back to Kristen's again, lack of clinical information. So what is it we need to know to be able to conduct that examination? So we generated our own referral guidelines, but you're right, they are guidelines, as are the authorization guidelines. They're there to assist. Somebody who's entitled to can overrule the guidelines if further information comes to light. So they're not set in stone, but they're there to assist.
Yeah. Okay. Thank you. Kirsten, maybe I have a query. Again, referring to incomplete clinical information. What are your recommendations or suggestions to improve the quality of clinical information on referral?
Yes, in addition to make some or to organize the radiographers' collection of clinical information in a more systematic manner. It's also obviously possible to do something with the referral sheet. So if many of the referrals template now are very broad, so it's a one field where you can say something about the clinical question or the clinical situation. But if you make the template more detailed, it might be a way of gaining more also detailed clinical information from the referring physician. So that is at least another option. But I think it's important not only for thinking justification when the referral arrive, but after all, when the examination is done, to have this proper clinical information added to make the examination justified, as the benefits of the justification is enhanced, and the final outcome for the patient is improved.
Yeah, great. Louise, any questions from your end?
I think Louise,
Okay.
probably frozen.
Yeah,
But
sorry.
Yeah.
Go on, Louise.
Yeah, no, sorry, I froze for a moment there. I have, there are 3 questions coming in actually. And one of the questions is related to if there's an unfortunate error in justification, how should it be handled, that situation? And is the radiographer held responsible? Would the radiographer be held responsible?
I can only speak from the UK legislation point of view, but if a radiographer justifies an examination or carries out an examination that isn't justified, then that would be dealt with as a radiation incident unless further clinical information is sought and it then becomes a justified examination. So again, there's an intrinsic link between the information that we're fed on that referral and the justification of that request. So going back to the question, it would be dealt with as a radiation incident. The radiographer would be held responsible if they justified something that is outside of their own local procedures. So within the UK, predominantly that's authorisation guidelines. And if an examination is carried out outside of the authorisation guidelines without any further clinical information being sought, then it is a radiation incident.
Okay. And obviously we're talking the UK regulations here, but the regulations in other countries could be very similar, or they could vary. So, but we just need to be cognizant of that
it's
as
all
well.
down to local practice as well. Not every hospital in the UK may have authorisation guidelines.
Okay, we have we have a question coming in, and it's a question about the regulations. Are the regulations creating a recipe book approach to radiographer justification rather than a respect for professional knowledge?
Kristen probably has a view about that. I certainly have a view about that. Do you want to go first, Kristen?
Well, a recipe book approach rather than respect for individual. I don't think we should be afraid of getting more regulation into this field, actually, because I think the opposite problem is bigger, that it's so random. Randomly handled, and more regulation would actually
going from that transition from being a radiographer, and I thought I knew everything that I needed to know to be a provided on that referral, and the knowledge that the person
Okay, thank
just
you.
have to say. I think it's within the College of Radiographers, the UK College of Radiographers have guidance on what that training should involve. Postgraduate education, for example, MSK report.
To do that.
I don't think at undergraduate level, I don't think once
No.
the 3 years training, no.
Okay.
I don't think
undergraduate degree programs, but taking account of what you're saying, Amanda, yes, maybe we could look at harmonizing
I did 18 months. That's what the program length was. The knowledge to justify every request that's coming through the door.
But still, I think it's if there's something they are in doubt of, and
how can the ISRRT help ensure clinicians are aware that it is a request rather than an order?
issue, the discussion between the referral and the request or the requisition, well, what we should call it, and how the clinicians look upon this if they see it as an order or not. And I think they should not see it as an order. I think it professional assessment of this referral when it arrives in the radiology department.
So, with that, I would like to thank all the
Ya, selamat sore rekan-rekan. Di ruang sebelah di workshop 2 masih berlangsung workshop forensik radiologi. Sementara yang rekan-rekan simak di layar saat ini adalah kamera dari workshop 1.
Dentists can use it or the odontologist can use it. It's not to the radiology department to design. No, just hand over the information. You can, of course, you have the traditional OPGs which are made.
Baik, kita akan berkeliling saat ini.
You can make curved MPRs which can.
Yang ada di layar rekan-rekan adalah exhibition hall, dan ini list dari sponsornya. Seperti yang terlihat di layar itu ada kolom exhibitor, kemudian platinum sponsor, silver sponsor, gold and bronze sponsor. Dari bronze itu ada Elekta, SFX, Philips, Medray, Detect AD, Axia, Irlandia. Saya juga baru tahu merek-merek ini. Baik, kita bisa berkeliling hingga pukul 16.20 waktu Indonesia Barat. Karena acara dari workshop 1 akan dimulai kembali pada pukul 16.20 waktu Indonesia bagian Barat. Kemudian di sponsor Gold itu ada Medica, ada HSL, ada Vision RT. Kemudian di silver itu ada Gorbet. Kemudian di platinum ada Agfa.
Of course, we have a lot of other
Dan
information within
di
those bodies, medical
exhibitor
devices,
itu ada
implants in jaw or
Agfa of
in
course,
eyes, etc.
kemudian radiograf
Even in
Radet,
penises, and we see
ini
on
dari
the left
Danish
image, you can see the 3D reconstruction.
Danish Council
Here
of
you have a view where you can
Radiographers.
say, well, maybe it's outside of the body, but if you make a soft
Danish
tissue reconstruction,
itu
you can see
di
the exact
Denmark, sepertinya
locations.
Denmark.
Even
Kemudian the Thai Society of Radiological Technologists, TSRT, kemudian Irish Institute of Radiography and Radiation Technologists, kemudian ini ada AFPPE, Association Francis du Personnel Paramedical de Electroradiology, seperti bahasa Inggris, bahasa Prancis itu. Baik, kita kembali lagi. Kita sembari melihat acara sesuai agenda. Kita coba lihat lagi karena ini sudah 4 menit lagi menuju acara. Kita simak apakah sudah mulai. Jika dilihat dari belum mulai. Nanti live stream akan dimulai pada pukul 10.20 waktu Irlandia atau pukul 16.20 waktu Indonesia bagian barat. Berdasarkan world clock, kita ada perbedaan sekitar 6 jam. Saat ini di Dublin di Irlandia itu pukul 10:08, sementara kita di Indonesia bagian barat itu pukul 16:08. Sementara di ini belum di restart. 16:16. Saat ini 16:16 persis ya. 10:16 dan kurang lebih 4 menit lagi kita akan mulai. Baik, kita lihat kembali ke network launch. Kita cek ke network launch. Di sini ada seluruh peserta. Seperti ini Presiden Salva Kumar dari ISRT, Indian Society of Radiological Technologists. Kemudian ada Profesor Patrick Brennan dari University of Sydney. Kemarin Mbak Irma cerita beliau ini adalah pembimbing dari Mbak Irma sewaktu kuliah di Australia sana. Kemudian kita lihat lagi, kita scroll. Ada Mr. Edward Chan, beliau dari Hong Kong. Miss Dennis Chong, beliau dari Singapura, beliau Presiden Singapore Society of Radiographers, ya, ketua parinya Singapura. Kemudian kita lihat lagi siapa yang hadir dalam kongres ini.
You see some metal implants and reconstructions of that ankle after a fracture. But even if you look
ya, Dr. Kathleen Kern, beliau adalah narasumber dalam kongres ini. Baik, kita lihat lagi siapa saja yang kita kenal ya. Rekan-rekan yang ingin mengirimkan salam dapat menuliskan pada kolom komentar. Jadi kita akan bacakan di sini. Kita cek lagi siapa saja yang hadir. 1 menit lagi acara akan dimulai. Baik, saya akan scroll saja. Atau mungkin kita akan skip, kita lanjutkan di waktu yang lain. Dan untuk diingat lagi, pembukaan nanti akan berlangsung pada pukul 19.30 WIB. Kita cek di main hall. Di main hall, apakah sudah dimulai? Karena waktu menunjukkan pukul sudah pukul 16.19. Ya. Baik, saya akan akhiri live report ini. Sampai jumpa. Semoga bisa disimak acara seluruhnya.
We're just waiting for the polling votes to arrive, and then we'll start again. Okay. This might take just a few minutes. We're just checking the technology to make sure everybody's able to vote this morning and participate fully. Polling votes to arrive. So just if everybody could bear with us just for a moment.
Maybe we can repeat the request, Louise.
Hi, everybody. We're back. We had a slight technical issue, which has now been resolved. So hopefully you will all now be able to vote. So we're just going to remind you of case one. So here we have case one on the screen. You can see it here. So if we go to vote now. So these are the three options. And if you're not sure, please do put that down. You may not work in MR. Okay. Yeah. And can everybody please just refresh your browsers just so we can see the polling results coming in after the technical issue? It would be great if you could.
Yeah, so just hit the F5 button. It should refresh your screen. And you should see the poll on the top right then.
Okay. So good, we've got results coming in. So the technology is working, which is great to hear. So we'll just wait for 1 minute and they'll be displayed. So we just have to wait a few minutes to allow everybody to be able to vote. It's just a slight lag. But they are coming in, which is great to see. And we'll just wait for the votes to settle down, and then we'll be able to report back to you. So we have good participation. And they're just being updated in real time. We have different votes coming in for this MR case. And once we finish voting, we'll go to look at the reasoning behind whether it's justified or not. So we hope to be going to that shortly. Okay, so the results are now on screen, and as you can see, 44% have said that the referral is justified, or it's gone to 40, while some have said it's not justified, and there are a number in the audience not sure. So I think we'll move back to Dr. Zarb, who will just discuss this case for us. Okay.
So, regarding this case, a patient referred for an MRCP, query gallstones. So in line with referral guidelines by the Royal College of Radiologists, an MRCP is a specialized investigation and should be used to investigate biliary disease only if earlier investigations indicate that a therapeutic ERCP will be required. The guidelines recommend infected gallstones. The request for an MRCP is not justified, but the patient should first be referred for an ultrasound examination. If the initial ultrasound is negative for stones, but demonstrates evidence of a dilated common bile duct, then MRI is justified, as MRI is more sensitive than ultrasound in demonstrating stones in ducts. And then, based on such findings, patient management can be directed to interventional ERCP.
Thank you, Frankie. We're going to move now, and I don't know if anybody has any further comment to make from the panel. At the moment, we don't have any questions submitted, but over time, when you hear what the panel has to say, if you want to submit a question or a further query, please do, and we'll be able to answer that after the cases or at the end. But are there any further comment from the panel, or should we maybe we should move to case 2? Following the technology just pause just to move on. So we'll move to case 2. So now I'd like to invite Amanda Martin to just speak about this case.
Hello. So this is a regular request that is received in many X-ray departments, and this is for a lumbar spine X-ray. And this is a referral on a 48-year-old male patient who has had back pain for 6 months. And that is the clinical information that we've received and on which we need to decide whether we're going to carry on with this examination or not. So please vote, and let's discuss it after the vote.
So everybody votes now. Hopefully you'll all be able to see the voting, how to vote on your screen. So for this very common query and common request in radiology departments internationally, is this request justified or not? Or if you're not sure, we'll just give it a few minutes. Like I say, it takes a minute or two. And any questions at all, keep submit them into the Q&A, and we'll be able to put them forwards for responses. Okay, so we have votes coming in. We'll just give it a few more minutes to allow everybody an opportunity. Okay, we should be very close to showing the voting now, so we can move to panel preview of the referral case. Okay, so now, as you can see, 60% of the audience say it's yes, it is justified. It's changed slightly. A third of the audience are saying no, and there's a couple of people not sure. So we'll just move now and let Amanda Martin just speak about this case.
So given the presenting clinical information, this examination is not justified. We would have to request further clinical information in order to go ahead with a plain film imaging of a patient of the age of 48 who's presenting just with back pain. So the things that we would be looking for are any what we call the red flag signs. So is there any early morning stiffness in the back? Is the response to analgesia? How long have they had the analgesia? What analgesia have they been taking? Have they got a previous history of cancer? Is there any history of weight loss? Are they a drug user? Are they systemically unwell? The majority of people over the age of 40 have got some form of degeneration in the lumbar spine. So doing a lumbar spine x-ray is just going to tell them that, yes, they have got some form of degeneration. If any of these red flag signs are there, then that may indicate that there's another more serious condition that we're looking for. And in that instance, we would do this examination. But given the information that we received for this patient, it is not a justified examination. It's not justified for mechanical back pain, which is generally muscular or just due to age-related degeneration.
Okay. Thank you, Amanda. And this is a common request, so maybe it provokes some questions in the Q&A. So I don't know if there's any further comments from the panel members at the moment. We're waiting for questions, so please do submit your questions. If we don't have any further questions,
I might just for a second.
Yeah,
then just
certainly,
echo,
Shane.
Just to echo Amanda's comments there, that I think we have to be aware that people over 40 years old, about 50% of those also run a risk of overusing it and maybe over-investigating. And over-investigation does have risks too, in terms of reasons we should be very cautious in our use of such imaging.
And I think this is probably a good example of where the extra knowledge for justification is needed. So understanding that
follow specific guidelines for give guidance to radiographers on the ground.
Yeah.
Yeah.
And again, I suppose just on that point, I think we all understand how these requests continue to be submitted and referred. I guess general practitioners and primary carers are under pressure. I suppose their patients often want to be imaged. They're looking for a solution to their problem. And 6 months of pain, I don't think any of us would be happy with 6 months of pain. So you do understand the patient's viewpoint as well. But again, it's about having evidence-based, I suppose, practice, and we can educate our patients as well as the referrers that are coming in. So it's about having that discussion to hopefully resolve.
Okay, great. So we'll move.
Post IV contrast CT brain scan on a 70-year-old male patient who's had sudden severe onset of headache. He also has papilledema, has had loss of consciousness, and the query is subarachnoid hemorrhage. So would you do a post IV contrast CT brain scan on this patient? So please vote now in the poll if you think it's justified, if it's not justified, or if you're not sure.
Okay, thank you, Adele. So we'll just wait for our voting to come in. Okay, we've got active voting at the moment. Okay, just wait for 1 minute to allow everybody opportunity for this CT request. Okay, we'll be closing the poll in a minute. So as you can see, it's kind of a split decision, split poll where we have just under 50% or so saying yes, it is justified, whilst approximately half the audience are saying no, and there's a couple not sure. So I'll move then, and we'll invite Idel to just talk on this case.
Okay, thank you. So if we just look at what the RCR guidelines recommend for this type of a patient, they do recommend CT imaging as a first-line investigation, but not post-contrast IV CT brain scan. So the initial investigation of choice, as you can see there on the slide, is that they would do a non-contrast CT brain scan, obviously to see if there's any fresh blood in the brain. They want to be able to see where it is, the distribution of it. They don't want to give IV contrast in that case. So the first line investigation is non-contrast CT brain. Usually then it can, if it's negative, it can be followed up with a lumbar puncture. And then there is a role for MRI if they want to further evaluate a dissection or any sort of vascular malformation or even problems with the pituitary gland, because we did see that this patient has visual disturbances, they've papilledema and they've things like that. There is a role for IV contrast brain scanning if you want to look at the vessels, but it's not done as a first-line investigation. So we can see that a CT angiogram may be done subsequently in order to get more information to see if there's something like a berryaneurysm or something that might be the cause of the subarachnoid in that patient. So we see RCR guidelines really recommend non-contrast CT brain, then possibly MRI, and then maybe CT angiogram or MR angiogram subsequent to that if they want to give the patient an intervention and if they want to further evaluate the vascular structures in the brain for that patient. So we know that CT angiogram is very, very sensitive and specific as well for finding aneurysms for these patients. So it's very useful as a follow-on investigation for the non-contrast CT brain. Okay. Thank you.
Thank you. So I don't know if there are any further comments. We have one question that has come in, and it's related to whether with any case, is it not that whether CT, ultrasound, MR are available or not, whether that would influence what you would proceed with, which is, I suppose, if of all, I don't know, speaking in relation to medical imaging, one would anticipate
it would be a very common first line examination to do on patients to get a baseline view of what's going on in the patient. In the patient in that case. But certainly radiation dose does come in, into it as well, as we
for the different outcomes of the different cases. But maybe we'll move on now to
the MRI. This was general practitioners or referrers would send patients for x-rays, just to maybe move it along. Guidelines, they're giving us what's the current best evidence, but sometimes if resources say we can't access MR, we can't access CT, then you do what's available too. So yeah.
Absolutely, yeah. So, sorry now. There we go. So our next case is, I'd like to invite Dr. Frank Zarb back to speak on this case. It's an MRI case.
Thank you, Louise. So our next case is a referral for an MRI of the right knee for a patient presenting with chronic knee pain. And the query is querying osteoarthritis. So is this referral justified in this case?
So we want you to vote now. Okay. Justified, not sure. If we have those votes coming in. And we do have people voting, which is great. It's great to see your participation. It's really important to the session. So I think we can close the vote fairly shortly, and we'll be able to come back and discuss this MRI case. Okay, they're about to display now. So if we look at these results, so we have a large proportion of the audience saying no, the referral isn't justified, with just under a third of the audience saying that yes, it is justified. So we'll come back and look at what the guidelines and best evidence would show.
So once again, referring to the iRefer guidelines by the Royal College of Radiologists, MRI of the knee is only indicated in specific circumstances where symptoms frequently arise from soft tissue, where soft tissue is not demonstrated on plain film radiography. So in this case, MRI of the knee is not justified, but plain film radiography of the knee should be carried out first to diagnose osteoarthritis. However, MRI is useful with undiagnosed pain when avascular necrosis, sepsis, or articular cartilage pathology is suspected. It is very important that we evaluate any previous knee imaging before accepting the referral. Thank you.
Okay. So these are just the points that Dr. Zarb just made. So I don't know if there are any further comments from the panel on this, or any questions. We don't have any questions coming in. It's obviously specific to this. It's a bit early, but any further comments? I think the situation with what imaging modalities available at the time may make a difference to how a patient is accepted or not, as we just discussed with the previous case. No further comments?
Please.
Yeah, sure.
If I may,
Please do.
And maybe it's something too, that's okay, there's nothing overt, or that there's no obvious pathologies or whatever, can really help people get back to recovery and back to full health.
Okay.
I would say, Shane, it is always a risk-benefit analysis.
Amanda?
Yeah, I think in this case as well, it's also about the appropriate use of the and as Shane said, it may inform then the clinical pathway for that patient. So they may then decide to go on and have a knee replacement, and that plain film will inform that decision. Pathway in the knee patient, the patient can have a knee replacement if the degeneration is extensive enough to warrant that.
Yeah. To our next case. So our next case is a CT case. So I'd like to invite Edel Thomas back to speak about case 5 for a moment.
Thank you very much, Louise. So here we have a clinical referral for a 62-year-old male patient. And this patient has shortness of breath that's producing gradually worsening symptoms of dyspnea on exertion over the last 2 to 3 years. But it's now acutely worse in the last while for this patient. They have a morning cough as well. And again, this is for the past few years. And now it's productive of yellow or brown sputum. The patient has no chest pain, no history of arrhythmias, no fever, chills, no leg edema, no history of PE or DVT, no history of malignancy, and no history of surgery as well. And we can just see as well that there is some information giving there in terms of this patient's vital signs. So we can see blood pressure 144/88, which is more or less borderline. The heart rate is 90 per minute, which is normal enough. The patient's temperature as well is 36.4 degrees Celsius, which is normal, and the oxygen saturation then is a bit concerning at 93%. So do you think that a CT pulmonary angiogram examination should be done on this patient? So please vote now.
Thank you, Adele. We're going to leave we'll leave the text up because there's quite a bit of text with this case just for a moment, and then we'll move to the voting slide. But the polling will be open now. So please vote. It's exactly the same. Yes, justified, no, not justified, or you're not sure. So we'll just let you have a look at that for a moment. Okay. And that's great. We have people polling. That's good. And as I said, if you're not sure, please do vote. You may not be working in CT, so you may not be as familiar. Okay, we'll just wait for a minute. I think we might nearly be ready to close the poll. Okay, so I'll just move to the vote slide. And the results are coming in. Should be visible now. They're coming up and they're just moving slightly. As we can see, there's a resounding no, not justified, with 75% at the moment, with 20% saying yes, it was justified, and a few people not sure. So now we'll go back and we'll just look at the evidence base for this case.
Thank you. As the majority of people have answered there, this examination is not indicated for this clinical history of this patient. So certainly a CT pulmonary angiogram examination is not the correct one to do for this patient. When we look at the clinical history of this patient, it really points to signs and symptoms of COPD or obstructive airways disease, so things like chronic bronchitis, maybe, or emphysema in this case. Their symptoms are gradually getting worse over time, but they are there for a long period of time. What they would probably do with this patient is to admit the patient and possibly do a chest x-ray, which would be indicated maybe to demonstrate if there is increased bronchovascular markings or cardiomegaly and things like that, and perhaps emphysema as well. So in this patient, they ordered a CTPA examination. If they wanted really to investigate this patient in terms of their vital signs as well, an ABG would measure oxygenation and ventilation for this patient. So if you were to do a CT examination on this patient, the type of CT examination that would best suit this patient is a high resolution CT examination and not a CT pulmonary examination, embolism rule out examination. If they did want to do a CTPA examination as well, just to point out on the referral that they really should note the Wells score and a D-dimer score if it has been performed as well, and that would provide possibly further justification if one was needed or not. In this case, the Wells score is less than 4, and so this patient is not at a high risk for PE examination anyway. If we go back and look at the clinical history again in this patient, we can see that they have no history of surgery, they have no signs of PE, they have no chest pain or arrhythmia or anything really that would indicate an IV contrast examination. So high-res CT would be the favourite in this case if they were to further examine this patient and not a CTPA examination. Thank you.
Thanks, Adele. Thanks for that. I'd just like to say as well, we realise in some of these cases we're using the IRIFA guidelines quite a bit in the cases. And there are other guidelines, there are other international guidelines that you may be using across the world. So
the patient. Obviously CT will give information in terms of where the PE is, what type of PE is it of, where the PE is, what type of PE is it is, and a number of other changes, like you might see infarct or other changes like that, changes relating to right heart strain on the CT scan. So if they want further information that would be associated with CTPA, CT investigation would certainly be good in that case. But they'd probably start treating the patient beforehand.
Mm-hmm. Okay, perfect. I don't know if there are any more Shane?
Yeah, I was just going to agree with Adele there. Yeah, so the current NICE guidelines from the UK recommend immediate interim anticoagulation once the Wells score is over 4. So while you're waiting for the CTPA, start the anticoagulation. So it is dependent on the Wells score and how likely the patient has a P will determine the anticoagulation. And I'm sure that's similar to other evidence-based guidelines as well in other countries.
Okay, perfect. Okay, we have more questions. We can come back to them at the end, but we can, sorry, is there anybody else, any further comment anybody'd like to make? I'm not sure.
No, I was just going to say as well, Louise, you know, in terms of the source of temperature as well, you know, it would indicate maybe because this patient has productive sputum in an active infection at this stage, an acute exacerbation.
6 is projection radiography. So I'd like to invite Amanda Martin to speak on this case.
Thank you, Louise. So again, another quite common examination of the calcaneum. And this case is a 54-year-old patient who's presented with plantar pain, and the GP is wondering whether the patient has a calcaneal spur, which is the source of pain. So would you justify that examination, or would you not justify it, or are you unsure? So please vote and we'll discuss it once the votes are in.
Okay, so everybody vote now. Again, this is a common request for projection radiography. Internationally, I'm quite sure. So if you'd like to vote, yes, justified, no, not justified, or not sure, that's fine. Just vote and we'll have a see how the votes are coming in. Okay. So it's great, everybody's participating. I'd say we'll be able to close this poll fairly shortly, and we'll look at the outcomes and discuss this case. Okay.
So this referral is not justified. Plantar fasciitis is a common occurrence that a lot of people get, which is pain in the sole of the foot. Now, a calcaneal spur can be the cause of that plantar fasciitis. It can be associated with plantar fasciitis, but it can be a normal variant as well. So we have to consider what the treatment might be, and the treatment wouldn't be for the spur. The treatment would be for the soft tissue condition of plantar fasciitis. So there is no indication to do a calcaneum X-ray for a patient where we are purely suspecting a spur.
Okay. Thank you, Amanda. That might spur on a few questions in our Q&A. Apologies for the pun, because this is a commonly requested projection.
And I think this is another example of where that further clinical pathological understanding that you gain through the postgraduate programs that we go on adds into the decision whether an examination is done or not, because we can't teach all pathologies on an undergraduate program to make these decisions.
Yeah.
Louise, could I just ask Amanda a question just very quickly? So you report skeletal X-rays, as do I. Do you report when calcaneal spurs are present on ankle X-rays or not?
I will comment on it as an incidental finding.
Okay. I don't know if anybody else has any comment from the panel. We've no questions coming in at the moment in relation to the calcaneal spur, but
can I ask?
Yeah, sure. Frank.
Can I ask a question to Amanda? Would an ultrasound be justified?
So ultrasound can investigate the soft tissue component associated with the plantar fasciitis, but it is very, it is dependent on the experience of the person who's doing the scan. So it would have to be done by a musculoskeletal radiologist to be able to understand the subtleties that are sometimes associated with the pathology. Yeah, so it would be beneficial, but they tend to do say you need to have had the heel pain for at least 6 months and it's not responding to any of the normal plantar fasciitis interventions.
Okay. And it's interesting because obviously the vote was very much for this is a justified request, you know, so the evidence would go against it being a justified request. So we have a couple of questions in, I'll just put one up. If this kind of this request had come from a GP, like in real terms on the ground, what does a radiographer do? Because they're presented with a request that we're saying isn't, according to evidence base, justified. So what should they do in that situation?
So we would reject the request on the basis that a calcaneal spur is a common normal variant, and the condition that is possibly causing the patient pain is plantar fasciitis, and we can't diagnose that on plain film imaging, and possibly suggest that if pain continues after 6 months and appropriate interventions, then further advice is sought with the possibility of doing an ultrasound scan.
Okay, thank you. All right, that's great. And again, we can come back to this at any point at the end. We're going to move on to case number 7 because we're halfway through the cases. We have a mix of cases for you, but now I'd like to invite Dr. Frank Zard back to talk about this MRI case for you.
Thank you, Louise. So case number 7 is a referral for an MRI of the lumbar spine for a patient involved in a heavy lifting as part of his work. The patient is complaining of low back pain together with saddle paresthesia. So is this request justified?
Okay, so everybody just consider this, and now we'll open the polling for this case. This MR case, which lumbar spine requests would be quite common referrals. So we'll just look at the polling coming in now to see how. That's great. We have active polling going on, which is good. So I think we can close this in a few minutes and we'll get back to the evidence base. And thanks again, everybody, for doing this. Okay. All right, I think our polling now has settled down and we should be able to close that and display it. Okay, so as we can see that over 2/3 are saying yes, it is a justified request. A quarter are saying no, not justified, and there are several in the audience not sure. So we'll come back and we'll look at the evidence base.
So the guidelines do recommend MRI for acute back pain for less than 6 weeks with potentially serious features, such as neurological symptoms, sphincter and gait disturbance, saddle anesthesia, severe or progressive motor loss, widespread neurological deficit, and other features, such as previous malignancy, immunosuppression, steroid use, and fever. So in such cases, MRI is the first-line imaging investigation. So in this case, an MRI is justified since the patient is suffering from saddle paresthesia, which is described as numbness and tingling along the inner thighs and lower groin. These are the areas that would be in contact if one was sitting in a saddle, hence the name saddle paresthesia. This is a red flag, and an MRI scan should be carried out as soon as possible in order to guide urgent intervention. Thank you.
That's great, thank you. And we'll just see if there are any further comments from the panel, if some questions are coming in. We do have one question coming in. If the patient comes, sorry, I just need to make it live. If the patient comes through accident and emergency with saddle paresthesia and MR isn't available, would it be best to do a CT scan in that case?
I think Adele.
Yeah.
We'll go to Adele.
I'll just answer that. You know, again, CT lumbar spine wouldn't be used that commonly, but certainly it will show if there's compression of one of the nerve roots, or if there's a reduction in the sort of the area where the spinal canal is due to maybe a prolapse disc or anything like that. So certainly it could be used as, you know, an alternative to MRI. If MRI is not available, it will give that information. It will be able to look at the discs and the nerve roots and the soft tissues as well as the bones that are there. So certainly quick and easy examination, but a high dose examination at the same time. But, you know, if it would help to guide the clinical course of treatment for the patient, then it would be justified.
Great. Okay, thank you. I hope that answers the question for the audience. That's great. I think we'll move to case number 8. We'll keep moving. And we've a CT case now, which we'll ask Adele Thomas to just introduce to you.
So this is the case for a 48-year-old female patient who had signs and symptoms of brachialgia, so cervical radiculopathy, or, you know, arm pain, thought to be due to sort of compression of a cervical nerve possibly. She also had neck pain and spasm, right arm weakness, and a post-IV contrast CT neck scan has been requested. So please vote and tell us whether you would do this scan, whether you think it's justified or not. Thank you.
Okay, so there we are. We'll see how the voting is. And we sincerely hope that you find these cases relevant, to pick cases that are quite common across different modalities, across projection radiography, MR and CT, depending on where radiographers are working in the imaging department. So we have the votes coming in, and we should be able to close that poll fairly soon now that voting is settling down. So, and again, at the end, your feedback will be really welcomed on the cases that we're putting forwards towards you. If you'd like to just comment to see whether you felt them relevant or not. Okay, and here come the results. Okay, so the results for this, is this referral justified or not? As you can see, a small percentage, under 20% are saying yes, it is justified, whereas 70% are saying no, and there are some that aren't quite sure. So we'll go to look at the evidence base for this case. Thank you, Adele.
Okay, thank you, Louise. So we can see that according to the RCR guidelines, this post-IV contrast CT neck examination would not be indicated in this case, especially as a first-line examination. So, you know, in this patient, there's no history of trauma noted at all, and there's no time frame as well noted for the onset of symptoms. And it would be useful to have that information as well, just to say that on the clinical request. But in this case, you know, the neurological signs and the age of the patient would favour an MRI examination as a preference to CT examination as well. There are no red flag features like vascular insufficiency. There's no trauma. There's no malignancy. There's no infection, inflammation, or myelopathy or anything like that. So they're all sort of red flags. None of those have been noted. So they're just requesting an IV CT neck scan for a patient who's got pain down their arm, which is coming from the neck. So just, you know, if they were to eventually sort of justify a CT scan in this patient as well, they wouldn't need an IV contrast CT examination. You know, if they're just looking for the nerve roots, they could do a non-contrast neck scan. But certainly MRI would be preferable in this case, you know, and if MRI was not available, then possibly CT might be used. So if CT or CT myelogram were to be used, you know, like I said, a non-contrast IV scan would be used, but a CT myelogram would involve obviously putting contrast into the thecal sac and then bringing the patient to CT and doing a scan through that region to be able to look at that area on the patient. So it's a far more invasive examination as well. It's not done very often in CT departments, but certainly MRI would be the investigation of choice for this patient. Thank you, Louise.
Thanks, Adele. So we'll open it up if anybody's any further comment from the panel, or while we wait to see if there are any questions from the audience.
Just to say as well, Louise, that for these patients, what they would usually do is conservative treatment as well. So patients with those signs and symptoms normally would have some sort of, you know, pain management, physiotherapy, medication, steroid injections and things like that. And eventually maybe surgical management could be considered in some cases if their condition does not improve. But generally, that's the way the patient should be treated in this case.
Okay, that's great. Sorry.
Louise, can I just ask on it again? Maybe Adele's pointed out, as have other referrals. Oftentimes with these referrals, there's information missing in terms of is there a history of trauma? I think that's vital to understand whether is it justified or not. And I guess is that a common problem? Maybe Amanda and Nick might answer maybe from their perspective clinically. Does it require a lot of interaction then with referrers when information is missing off of these?
Yeah, I think this goes back to what Kristen presented this morning as well, that quite often the clinical information is not enough to justify an examination. And when you do some delving, and this is right across the board, when you do some delving, you actually find out a little bit more that then warrants that examination to be justified. I'm sure the others would agree as well, hopefully.
No, sorry, jumping. Yeah, I absolutely do. I think so. I do a lot of chest imaging, and cough, shortness of breath is the one word. Busy ED or inpatient clinician referring is really, really frequent. All you need to do is open the notes and find they've got raised CRP or chest pain or post whatever. Part of it is everybody is busy. Part of it is, again, and I'll come to it on my case, is keeping the patient at the center of, if you can quickly check the record yourself rather than just outly rejecting or declining to perform an examination, how can we fit the pieces of information that are available to us to make sure the patient gets timely imaging that is appropriate? And I think that's, like everything in life, it's a balance.
And that also feeds into the report as well. So just thinking back to a case last week that I reported, or I was reporting, I excluded something as a normal variant, and then the nurse appeared alongside and gave me more clinical information that I then decided it was a fracture. So it goes right through the patient pathway, that the busyness of departments now, people just tell us what they think we need to know, which isn't often enough.
Okay. Great, thank you. Okay, so I don't think we have any questions at the moment from the audience related to this case on case 8. So with time in mind, we're moving to case 9, which is a projection radiography question. Well, case, should I say. So I'll invite Amanda to speak about this case.
Thank you. So this is an 84-year-old lady with a referral for a pelvis x-ray and both hips. The patient had decreased mobility. She had pain on movement in both hips. She had a tenderness on palpation, and the clinicians wanted to rule out fracture. So is this examination for pelvis and both hips justified or not?
Okay. So we'll go to polling, and this is a very common request. I'd say a daily request across radiology departments internationally. So
and I think we tend to see these kinds of requests on patients who don't have the capacity to give a proper clinical information.
Yeah, absolutely. So it'd be interesting to see the audience respond response to this. So you're all polling, which is great. And we'll be able to put this up in a moment. Okay, so I think our poll has settled, so we could possibly have a look at the results of that poll as the results are coming in. Like I say, very common request. Okay, so here come the results. So nearly 80%, 75% to 80% are saying yes, this is justified. No, 20% of the audience are saying no, it's not justified, and then we have a small proportion who are not sure. So we'll just see what the evidence would say to us.
Yeah, so it's a little bit of a split camp, this. So the request is justified for the pelvis, but it's not justified for lateral projections of both hips. So if you've said yes, you're correct in that it's justified for pelvis to include both hips, as in AP, but it's not justified to then go on and do lateral projections of the hips. There's no history of fall given, there's no so the likelihood of fracture is minimal. So the advice would be to continue with an AP projection of the pelvis and then progress on the findings for that examination. And if it's very clear that there are no fractures, then send the patient back to the referrer, and then if further clinical information is provided that requires lateral hips, then we can go ahead and do them. One of the considerations for this patient is the position that you have to get the patient in to do the lateral hip. So elevation of one side and then elevation of the other side will make it difficult if truly they've got fractured neck of femur. So this is another one where you're potentially needing to seek more clinical information and marry that up with the AP projection that you've already got. I think Louise is frozen. Yes. Yeah. So does anybody have any questions? Nick, do you want to add anything to that as an MSK reporter?
No, other than lateral hips have very, very, very limited information or requirements for it, possibly in some erosive arthropathies or infection, but yeah, it's AP pelvis is where all the information is.
Yeah.
Thanks, Amanda. Sorry, my internet was unstable for a second there, but I'm back with you. I don't know if we've... Yeah, we'll just have to share my screen. Sorry about that to the audience. There we go. Hopefully you can see that now. Yeah, apologies for that, everybody. I don't know if we have any questions from the audience for this case. I don't believe we've any coming in. We had one question coming in, would CT be better? But I'm not sure I'm not sure if that's related to case 9 or not, you know,
I can answer that for case 9. So
yeah, sure.
If there is a suspicion, more information comes to light, and there's a suspicion for an occult hip fracture, then yes, potentially CT, but digital tomosynthesis may be beneficial for this patient.
Okay, that's great. Thanks, Amanda. Any more comments? No. Okay, we'll move to our next case then, case 10. So another MRI question, case. So I'll ask Dr. Frank Zarb to just introduce you to this case.
Yeah, thank you, Louise. So for case 10, we have a referral for an MRI of the brain for a patient with a history of breast carcinoma. And the patient recently complained of dizziness and numbness. So we need to see whether there are any brain metastases. And because of this, the patient was also referred for a CT thorax, abdomen, and pelvis to assess for abdominal metastasis, where both scans, the MRI and CT, should be performed on the same day. So the request for justification here, the question is for the MRI of the brain. So is this justified or not?
Okay. So I'll leave the text up for a moment while you're looking at it and polling, but the polling should be open now. Okay. Okay, so if you pull, I'll just leave it there because there's a little bit of text to help people to have a look at it. Okay, and we'll just give it a moment or two. Okay. And now I'll just move to the next slide because we'll be able to put the poll up very, very shortly. Okay. Yeah, there we go. So the results are coming up now. And if we look at this, we have a split decision as whether it's justified or not. At the moment, looking in real time, we have 40% saying yes, it is justified, with 50% saying no. And then there are a few in the audience who aren't quite sure about this particular case. So we'll just look at the evidence for it now.
So once again, referring to the guidelines, which recommend MRI as the imaging investigation of choice for the brain and spinal cord. MRI is more sensitive than CT, as CT may miss small tumors and also has suboptimal image quality in the regions of the posterior fossa and the spine. A contrast-enhanced MRI is required for the demonstration of brain metastasis. So in this case, MRI with gadolinium-based contrast administration is indicated as it is more sensitive than CT. Since the patient is also being referred for a CT thorax, abdomen, pelvis on the same day, the CT examination should be carried out before the MRI examination. If not, concentrations of gadolinium retained in the kidneys will attenuate the X-rays during the CT examination and may be a cause of misinterpretation. Since both CT and MRI examinations require the administration of contrast, reference is also being made to the European Society of Urogenital Radiology guidelines, which recommend that for a patient with a normal renal function that is having an eGFR greater than 30, a minimum of 4 hours should be allowed between scans. While for a patient with severely reduced renal function that is having an eGFR less than 30, then a minimum of 7 days should be allowed between scans. Thank you.
Okay. That's great. Thank you, Frank. So there's a lot of information on the slide here. We can come back to any questions on this. We'll see if there are any comments from the panel. Okay. So I don't know if there are any comments.
I might jump in there, Louise, just for a
Yeah,
second.
Shane.
And again, just from a very practical viewpoint and maybe down to availability, I think the guidelines are correct. MRI is definitely more sensitive for the brain. But oftentimes, I suppose my experience, you'll find that patients will actually probably end up having the CT brain done as part of the thorax, abdomen, pelvis because it can be done or it's available. And perhaps not all centers are able to facilitate urgent brain or MRI imaging, depending on their resources.
Can I just say something, and maybe Adele can confirm or otherwise what I'm going to say? If the CT brain is done for metastasis, then a higher dose of contrast is required to increase the sensitivity of the scan?
No, I don't think so. But what you would need to ensure is that the thorax, abdomen, pelvis is done first, and then you can go back and do the CT brain. Because ideally, if you have a waiting time of maybe 3 to 5 minutes or something like that post-contrast injection, it's the best time to look for brain metastasis in CT. Because, you know, with the breakdown of the blood-brain barrier that has occurred due to the tumor or the metastasis or whatever it is, it'll give sufficient time for the contrast to seep through that broken down blood-brain barrier. So CT-TAP first, thorax, abdomen, pelvis first, and then after that, just go back and do the CT brain scan if you are doing it instead of MRI. But yeah, no extra injection would be needed in that case.
Thank you. In fact, thank you for the information. That's great. I hope that answers a few questions in the audience. Okay, we did have one question coming in. Since the patient's already gone a CT abdomen pelvis CT scan, would an IVCM wouldn't be practical to perform a post-IVCM brain as well?
I think that's already sort of been answered in the last
yeah,
question.
It has, yes. I was just reading it out live as it came in.
Yeah, no, it's just if you've done the CT body, wouldn't it be practical just at the time maybe to do CT brain scan? And like Shane said, in a lot of cases, that's probably what would happen. CT is very reliable still for picking up metastasis, although MRI is the gold standard, but you know, you'd be able to find any metastasis there, hopefully.
Yeah. And thank you for the question. We're just seeing them coming in live, so they're coming in quite quickly. We're just reading them quickly. So that's great. Now we're nearly, we have 2 more cases left, and then we'll have a few minutes at the very end to answer any outstanding questions. So maybe we'll just move to case 11. And case 11 is for Idel Thomas. I'm going to invite you now to speak about this one.
Thank you, Louise. So again, this is a request for a CT abdomen and pelvis scan post-intravenous contrast for a 21-year-old female patient who's got a history of ulcerative colitis. And so at the moment she's presenting with fever, severe abdominal pain, vomiting and bloody diarrhea as well. So the history of ulcerative colitis in this young patient. So would you do a CT abdomen and pelvis examination post-IV contrast? So please let us know if you think this is justified or not.
Okay, so I'll leave it up for a minute while you're voting. So we'll just wait for a moment. Okay, and we shall just move to the vote and let everybody vote. So our votes are coming in. Okay, and I think, yeah, our votes are coming in live now. We'll be able to close shortly. Okay. Okay, I'll just put it up for a moment as the votes come in. And I think we're settling down now to maybe close the poll. Okay. So here are our results showing on screen. So a third of the audience is saying, yes, this is justified, 50% saying no, and we have a large proportion than in other cases saying they're not quite sure on this case. So we'll let Idel talk about the evidence base for the case.
Okay, so for this patient, it is indicated to do a CT, an IV CT abdomen examination for this patient, because really the clinical history points to the fact that there's an acute exacerbation of their ulcerative colitis. So, you know, this means obviously it's worsening, and in acute severe ulcerative colitis, you know, it is a medical emergency. So you're going to be looking for maybe things like, has the patient got an abscess? Might there be a perforation there? Or, you know, what is going on in the patient? And in that case, CT is certainly like a wonderful imaging modality for demonstrating not only the extent of colitis in the patient, but also all these maybe extra colonic findings that can accompany this patient's disease process as well. So you can not only sort of look at the colonic wall and the mucosa, you know, you'll be able to see on CT if there's any swelling of the mucosa, if there's any bleeding in the mucosa, if there, you know, CT's not very, very sensitive for showing that, but you might see things on CT like the target sign, which will demonstrate that there is swelling between the different layers of the bowel wall for these patients. Another thing you might see is strictures as well on this patient. So certainly CT is indicated, and we can see there according to the RCR guidelines that it is indicated for further evaluating this patient. Just some things to note about this request. So it was a young patient as well. There's no LMP noted on the request, so as we know, that would be essential to include and to find out, you know, prior to justifying this examination and proceeding with any CT examination on this patient. And we'd normally try and advocate a low dose protocol on these patients, because sometimes they come back for serial CT examinations over the course of their disease. Obviously a young patient, and there's the potential there that they will have future CT examinations as well. So every effort should be made to use a low dose protocol, use iterative reconstruction, but also bearing in mind that we are looking for subtle changes sometimes in the bowel wall in these patients. So, you know, not to have the images too noisy, you know, a low dose protocol should be applied, but we need adequate signal to noise ratio as well to be able to make that diagnosis for the patient. So contraindications to intravenous contrast agent need to be checked, and EGF4 as well, prior to going ahead with the intravenous contrast for this patient. You may consider giving a neutral oral agent to the patient to better visualize the bowel wall in this case, and any complications associated with that. A neutral oral agent would be something around about 0 to 10 Hounsfield units values. It could either be water or it could be a proprietary agent, but it will help you know, to evaluate the bowel quite well in this patient, and to see the outline of the bowel wall, and that's enhanced with IV contrast compared to the neutral agent that's in the lumen of the bowel. Another option would be CT enterography, which is really just a CT examination of the abdomen pelvis, but with a larger amount of oral contrast or neutral agent given to the patient, again, just to see more things. So instead of giving maybe a litre of oral, you might give a litre and a half or 2 litres if the patient's able to tolerate it. But we did say in the beginning, this is an acute exacerbation of this ulcerative colitis for this patient, and they're very unwell, and if they're vomiting, you know, quite often they will even just waive giving this patient any of those types of preparations, and just proceed with an IV examination for the patient in abdomen and pelvis. So that sort of covers the things in this case.
That's great. Thanks, Adele. Thank you. So I don't know if there are any further comments on this CT case that anybody wants to make, or we can always come back to it. No, at the moment. We're on to our final case, everybody, our final case for voting. And then we do have a couple of questions we can go to at the end. Now, our final case is one that we will all be familiar with because it's projection radiography. And I'm going to invite Nick Wojska to talk about this particular case. Okay.
Fabulous. Thank you, Louise. So the final case in the justification session is for a 68-year-old female who's presenting with right posterior rib pain of uncertain cause. She has a history of breast cancer treated with mastectomy and axillary node clearance 4 years prior. So moving to the poll, is it justified? Yes, no, or unsure?
There we go. Yes, no, or unsure. Okay. This is a case that really we should, as radiographers, we're probably all very familiar with. Okay, so our voting is coming in fast and furious for this final case. You've all done exceptionally well voting all the way through these cases. Okay, I think we can close this case in a minute. It's settling down. We'll just give it another moment. Okay. We'll just let it settle. Actually, it's still moving around our polling. And again, thank you everybody in the audience for going through the cases with us. We really hope the information that's been provided is of value. And obviously, as we said, there are different guidelines and different protocols that people will be following, and we're completely aware of that. This is okay, so we're ready. I've been told the results are coming back on screen now, so we'll have a look at it. So in our final case for this chest x-ray, is the referral justified or not? So 65% are saying yes, it is justified, 31% saying no, and a couple in the audience not quite sure. So I'll leave the evidence base to Nick. Okay.
Fabulous. Thanks, Louise. So 2/3 people came in with yes, it is justified. In this case, it is. Chest X-ray is a very low dose, low risk, readily available test which can be performed in a range of clinical settings quickly on an unstable patient. The yes, given the history of malignancy, if with previous breast cancer, it can also be treated with radiation therapy, which can predispose to rib fractures. I think recently, anyway, the management of rib fractures have changed. So having an isolated or multiple risk of morbidity for an inpatient stay. And again, feeding back, I might be jumping into the Q&A bit, but thinking of the, there's a PhD thesis done in Australia, which is the referral game. So if someone says query rib fracture post-fall, radiographer says, no, I'm not doing it. We don't x-ray for rib fractures. Patient goes back to the emergency department clinician. They say full query pneumothorax. Patient 2 hours later comes back and you do the x-ray. And so part of performing appropriate imaging where required is making sure, yes, that decisions are evidence-based, but also thinking so where is the patient going to be? How am I going to make sure that this patient gets appropriate treatment and management? And I think the guidance around rib fractures is changing.
Okay, thank you. We'll just move on to open questions. I don't know if any panel member has any comments. There are a couple of questions coming in from the audience.
I have, Louise.
Yeah,
to add on to what Nick said, there's this rapidly building theory called silver trauma, which is associated with rib fractures and other innocuous injuries in elderly patients that have significant outcomes. And one of those, as Nick said, is the association between rib fracture and the number of rib fractures with then morbidity. And so, yeah, the theories are changing around whether we should x-ray for rib fractures. And the other thing is then, do we just limit it to the chest x-ray, or do we also go on and do oblique ribs? What's your advice on oblique ribs, Nick?
I think I suppose it depends. So if you've got someone who has a high clinical suspicion of rib fractures, you can't say it. So I had to give case of part of a sort of a inpatient death of was there actually rib fractures identifiable on the admission chest x-ray or not, because they had a fall in the hospital. And because it was lower ribs, the mobile AP chest x-ray on admission was insufficient. You just couldn't, no matter how much you tried, you couldn't even see the ribs to work out whether there was a fracture or not. I'm increasingly of the view that if the acute management is whether there's a pneumothorax or not, so in an emergency setting, yes. If the patient's stable enough and it will affect management, then yeah, I'm swaying more towards performing oblique ribs than I ever was.
Yeah, I suppose it will guide, and this, a lot of it will just come back down to, will it guide patient management? Well, yes, because the lung hygiene, there'll be more emphasis put on to good pulmonary hygiene, etc., etc. So yeah, I think I'm with you on the oblique ribs.
Although I would jump in as having been a reformed Australian radiographer, oblique ribs are just done as routine.
Yeah.
And this is, the sort of the differences in practice. This is the international conference. I think, the accepted practice in different settings is vast. So I think the UK is an outlier in not routinely performing lateral chest radiographs. Very much an outlier. Whereas, in most other places, you routinely perform a lateral as part of a standard chest radiograph referral.
Okay. It's very interesting. As an educator, it's very interesting to think oblique ribs when we don't routinely do them, maybe re-emergence. But it's a good discussion. There are a number of questions coming in. They're related to different questions. Now, we are coming close to time, which I'm very aware of. So I think what we might do, we will be able to respond to some of these questions actually within and write an answer in response to them in the open format might be the best way to go ahead to keep us on time. We sincerely, just speaking on behalf of the panel here this morning, we sincerely hope that you found this interactive session useful and the information was of value, and it stirred some level of debate, because obviously the practices are going to vary so much internationally, and we're very aware of that and the guidelines, but we hope it's been of professional value to this morning. And I'd really like to thank all the panel members for their time and efforts in making this justification workshop possible. We do have one speaker, our final presentation, which we're going to shortly. Okay. So, and again, if you've any further questions, just keep them coming in, and we're still looking at the Q&A sections, and we'll have it open till the end of the workshop. But we're going to a recorded presentation shortly from Dr. Mary-Louise Ryan, who's going to be talking to us now to close this workshop in relation to auditing referrals and incident reporting. So we'll come back to you shortly after this recorded presentation to do a final closure and a final Q&A. Okay, thank you.
Good afternoon, everybody. My name is Mary-Louise Ryan, and I am a lecturer in Dublin. I have extensive experience in quality and risk management in radiography departments. And today I'm going to talk to you about auditing referrals and clinical incidents in relation to justification. I have nothing to disclose. I'm going to begin this talk by focusing on our minds on what a quality approach means. Internationally, 10% of patients will have an adverse event in hospital, ranging from an adverse drug event to experiencing a healthcare associated infection. We need to have a quality approach to keep us and our patients safe, to allow us to have effective and efficient services, to have a patient-centered focus, to be proactive and identify problems before they will occur. And also, having a quality approach is internationally recognized as being very cost-effective. It might take a cost to have it set up. However, in the long run, it saves money because you get away from having adverse events and patient incidents. Clinical audit is defined as a quality improvement process that seeks to improve service user care and outcomes through systematic review against explicit criteria and the implementation of change. It is a key component to a quality radiography department. The fundamental objective of clinical audit is to ensure that the quality of care meets clinical standards. It is highly beneficial because it gives us a way to assess and improve patient care, to uphold professional standards, and to ultimately do the right thing. It can be very educational for the people that carry out the audit. You work with evidence-based standards and really understand what's going on in your department. We also identify risks, and we can measure those areas of risks to the service. And it helps to create a culture of quality improvement in the clinical setting. We really need to stop and think about what are we doing now and what do we want to do or should we be doing? There are many useful guidelines internationally on clinical audit, one of which is the online e-learning course on the Isrrt website. The European Society of Radiology Audit and Standards Subcommittee have produced Esperanto, a guide to clinical audit in radiology with clinical audit tools. It's designed to support radiology departments in developing a clinical audit. There's many useful audit tools and reference to European legislation. I would advise you to download it and the many other audit tools, which are all free of charge. When we consider clinical audit, it is best to focus around the audit cycle or the audit loop. Firstly, we select our topic and objectives, and we set criteria and standards and indicators against evidence-based practice. We then collect our data, which can be done in a number of ways, and it's often done by looking at documentation or images, but also we can observe areas and look at policies and procedures. We observe that current practice and compare it with the standards, and we make an assessment to implement change and evaluate the results of that change by re-auditing on a regular basis. I am going to present to you some considerations under each part of the audit cycle relevant to the topic of justification. Often our first objective clinically is to evaluate how many referrals are justified and unjustified. And indeed, most of the audit literature on justification in clinical audit focuses on this. Esperanto offers other key areas that should form part of your clinical audit, which I've brought under the broad headings of process and workflow, radiation dose, and the most appropriate imaging examination, and education and information. If it's not written down, it didn't happen. The purpose of healthcare policies and procedures are to provide standardization for daily operational activities. They help because we have clarity with issues and activities that are critical to health and safety, legislation, and regulatory requirements. They are shown, policies and procedures are shown to reduce patient harm because there is improved standardization and communication. And the importance of accurate documentation and complete documentation is really vital to demonstrate that standards of care were maintained. So it's really important for the patient, for the radiographer, and the healthcare institution. On this slide, you can see suggestions from Esperanto to audit areas such as, is there a written protocol for who is responsible for justification for radiology examinations? Who is identified as responsible for the justification process? Is there a written protocol around health screening and justification around health screening? Or around pre-exposure justification discussions? So are the policies and procedures in place, and do they address all the issues that are relevant to justification? In the area of education and information, Esperanto suggests that we audit provision information to support justification and whether there is evidence of appropriate training for individuals with regard to justification. Education and training of healthcare professionals who request examinations provides the knowledge and competence required to ensure best justification practices. All staff should have this sufficient training to understand their roles and responsibilities in the justification process. There are many documented challenges with this, including what constitutes appropriate training. An ongoing audit may help to shed light on areas where education is most needed and what type of information is required. And then you can come up with a really practical approach. We're all very busy and we're all very stretched in healthcare already. So having that practical approach and identifying the areas that need the most education is really important. There are many papers and literature that looks at audits across the different modalities and different imaging areas and whether what was appropriate or not from a justification perspective. I've picked out a couple here, but there are many more. The key themes that come across is that there is an issue with justification. We can see there in the top slide, in the top of the slide, around a national audit in Luxembourg on CT and MRI referrals, where 79% of MRIs were appropriate, but only 61% of CT examinations. These vary from modality to modality and from country to country. However, that underlying theme that justification needs to be improved is always there. When talking about workflow, I'd like to give you an example of a study we completed in UCD with 2 large hospitals, where we focused on clinical justification in mobile chest radiography, comparing it with departmental chest radiography. We all know the challenges with mobile X-ray examinations, including radiation dose width, reduced image quality, and staff time demands and carrying out these examinations. Indeed, a large USA study revealed that 60% of ICU patients receive a daily chest examination, despite recommendations in doing so by the American College of Radiology. In this study, we audited 216 mobile and 215 departmental examinations. There were 117 unjustified referrals identified in this audit, which represented 27% of the examinations were unjustified, and not a huge difference was noted between mobile and departmental examinations. We used documented costings, and based on just the examinations in this audit, a cost saving of almost €6,000 could have been made if we got justified referrals. And this is based on staff time, workflow, equipment, and we really need to focus our resources on where they are best placed at the moment, so we can see the impact of justification, not only on radiation dose, but certainly on workflow. Another example is where we audited 1,158 CT referrals for justification across 5 clinical sites. 488 were performed outside of core working hours, and the rest were performed in the general day-to-day working hours. So these were the 9 to 5, and then outside of the core hours were night times and weekends. Overall, 11% of examinations were not justified, 12% during working hours, and 9% outside. Justification varied widely by anatomical region and examination, with 28% of CT pulmonary angiogram scans being unjustified, and just 3% of scans involving the kidneys, ureter, and bladder. 37% of scans were deemed inappropriate for completion during on-call hours based on urgency. Although there's not a major difference between the justification during core hours and on-call hours, imaging is more costly on call, for example, as radiographers and radiologists may have to attend the department overnight. So this was a really powerful audit to see where cost savings could be made, and indeed radiation dose savings could be made. Moving to considerations when setting your standards. Whilst we aspire to have 100% justification, there is always room for clinical judgment, which may not fit within the box of an audit and be evident. So we need to be realistic in what we expect. In the beginning, I would suggest a lower target of maybe 70% justification. And as you implement your changes, move that target to a higher level. The second point is to be mindful that national and international guidelines may not always suit your department, and you need to consider local practice. We certainly saw this in the chest X-ray audit, where mobile examinations had their own set of criteria locally, which did not necessarily align with the international guidelines. And it's important to take that into account and consider it at the beginning. And as always, clear, concise standards that facilitate repeat audits are really important. So looking at considerations when completing the audit, we cannot separate the quality of the image referral from assessing justification in the audit. They are very difficult to separate. Imaging referrals are that essential communication tool between the referrer, radiologist, and radiographer. And guidelines state that the referral should have adequate clinical information. There is no misinterpretation. However, multiple studies have shown that clinical indications that are poor actually affect the interpretation of the radiology examination. If we're auditing retrospectively, it can be a challenge to fully decide if something is justified or unjustified based on the clinical indication if it's poor. So I would suggest building that into your audit, as we did in our CT justification audit. You also need to consider the perspective of the auditor. Is it a radiographer? Is it a radiologist? Might they think differently about justification? Again, you need a thorough audit tool for understanding, and think about other considerations that we have started to think about around the time of the day, whether it was a departmental exam, perhaps the age of the patient, who the referrer is, and see if you can see any trends, because that will help you make your changes. Just to focus for a moment on audit tools. You can have a very simple audit tool like the one on top, where you just note whether the exams were justified or not. However, you can go into a lot more detail like the bottom one, which looked at lumbar spine examinations. And you can see for what indications were they justified or not justified, who the referring physician is, was it a positive or negative result, what time of the day it was happening. So you get that better information, and then you can understand more if, perhaps it's one or two staff that accept everything. Is there a time of day where unjustified referrals are accepted more? Are we doing too many scans for lower back pain and need to do an educational piece on that? So it is really helpful to have a detailed tool to gather that information so you can do your change. So talking about change, there's no point in engaging in audit if you're not going to implement change. Whilst the value of the changes has not really been documented very thoroughly in the literature, suggestions have been made, including education and training, artificial intelligence and clinical decision support systems, reviewing policies for refusal, and clinical audit, obviously being a key tool. Indeed, the ESR have recently kicked off their study on improving justification in CT examinations, with one of its aims are to identify areas for further action and opportunity. Sometimes it's not so easy to identify what the key issues are. And if you have a small amount of time or money to implement change, you want to use it in the best way. I have found that root cause analysis, which is commonly used in quality improvement, is a really useful tool. So I'm going to ask you, why did the Titanic sink? This is a picture of the Titanic. I'm sure we've all heard of the ship. And if you asked me this before I engaged in this root cause analysis, I would have said it hit an iceberg and it sank a few hours later. Let's complete a really short root cause analysis on that though. This was the captain of the Titanic. And again, many of us know his face. And his name was Captain Edward J. Smith, very experienced and commissioned to command the Titanic. In January 1889, he ran aground the Republic boat in New York. In 1890, he ran aground the Coptic in Rio de Janeiro. And in 1909, he ran aground the Adriatic outside of New York. He had a history of running ships too fast through narrow passages and not adequately training his staff. But he was commissioned to command the Titanic. On its last voyage, we can see here, he received at least 6 warnings of an ice field from ships in the area. He had no binoculars in the crow's nest. He was traveling over double the speed whilst trying to break the transatlantic record. So I will ask you again, why did the Titanic sink? What fed into that? What were the key areas that maybe could have been improved or changed? And it's, I think, a lot more challenging than just that it hit the iceberg. So root cause analysis really helps you get to the root of that problem, and it's often used in major incidents, but sometimes it's really helpful even in just an audit setting, especially if you have a recurring issue. There are other various methods for quality improvement, which include brainstorming, cause and effect, the 5 whys, and 6 sigma, which can also be used. And I would encourage you to have a look at. So when we need to think about incident reporting. So when does an unjustified examination become a clinical incident? This is a big question. It's a question I'm not sure I can answer today, but I think it is something we need to start thinking about. So let's remind ourselves of some key definitions around risk. So risk is the likelihood that a person may be harmed or suffers adverse health effects if exposed to a hazard. And a hazard is a potential source of harm or adverse health effect on a person or persons. Error is a deviation from the expected norm, regardless of whether it results in any harm. An adverse event is an occurrence with harmful consequences to the patient receiving care. And a near miss which is really important in this area, is a subset of adverse events in which the patient fortunately sustains no harm. Think about driving home this evening or driving to the beach or somewhere nice, and you drive through a red traffic light, which I'm sure none of us will do. The error is driving light. If you have an accident, that's the adverse event. But if you drive to the red light and get away with it and don't hit somebody or hit another car or get caught by the police, that's a near miss. So nothing adverse happened, but it was a close call. Adverse events are categorized across a spectrum ranging from a near miss to loss of life. Clinical incidents related to justification. I'm just giving some examples here, but I believe there are many more that we need to think about. One of the key ones and the most important is that if a patient is having the incorrect examination to find their pathology, then they may have a missed pathology due to that incorrect examination. Of course, radiation dose is a key issue in many modalities, as is procedural implications, such as giving a patient contrast if they don't need it. And also resource issues, which I've mentioned before. If we have 20% of referrals that should never be done in the first place, then we are wasting resources and reducing efficiency continuously. Putting error and risk in the context of justification, there are a couple of things we need to consider as a profession and indeed at local level. This is a risk matrix, which is a tool for ranking and displaying risks by defining ranges for consequence and likelihood. Looking at the matrix, which is internationally used, we can see issues with justification are possible, likely, and probably almost certain, depending on what your audit finds. The effect then depends on the outcome. Is it simply not a big deal? Could happen, or is it the patient has been completely misdiagnosed? Another model that's important to think about is the Swiss cheese model. So it was originally proposed by James Reason and has a long and proven record of effectiveness in managing risk. So the holes in the slices of cheese represent weaknesses in individual parts of the system and are continually varying in size and shape and position. So the weaknesses could be lack of training, and they could be lack of a robust policy or procedure. So if there is a failure in the system, each failure moves through a hole in the slice of cheese, and then it leads to an overall failure where a patient is potentially misdiagnosed or a resource issue comes into place. I want to focus on one issue that is really pertinent to the Swiss cheese, and that is having a robust clinical incident reporting system. It is really important to have this in place, something that works really well, that is quite slick to work. It doesn't involve mounds and mounds of paperwork. It's a really good feedback mechanism for staff. There should be a documented agreement on what constitutes a justification near miss and a justification incident. Everybody should understand that and be able to document it simply in their day-to-day practice. It needs to be practical, and it needs to focus on leading to improvement in your department. Otherwise, it's not appropriate at all. A lot of research has identified so many advantages to recording and actioning and reporting near-miss events. So when it almost happens, when you catch that and then you query the justification, awareness is increased around the subject matter by reporting of incidents, and it increases the likelihood of initiatives and funding being put in place to reduce that risk occurring. So in several papers, this is highlighted. So we need to start documenting our near-miss events and indeed our incidents. If you see here, if I was a manager and have been, and I have one or two near misses or incidents on my desk, I'm not going to focus too much on what it was all about. We might document them and give some feedback, and that might be it. However, if I have lots and lots and lots of incidents and near misses on the same topic, I will definitely pay attention and start to do something and start to work on this so that we can reduce them. And indeed, a near miss is a great way of documenting it because we start to see the problem, and you can even audit your near miss events. So I would strongly suggest that you agree these principles in clinical practice and start documenting them so that we gather the information and can really improve things and reduce the risk to our patients and ourselves. There are a number of barriers to incident reporting documented, and it's a common trend throughout the literature. So things like workload increase, concern over disciplinary steps if you're part of the incident, a lack of belief that resulting and useful change will take place, a lack of feedback to staff. So there's no point in documenting a near miss or an incident and you don't find out afterwards what happens. There has to be feedback to staff. Issues with the incident form and the process itself, something that you think was trivial and may not happen. And that's why it's really important to have that in a policy so it's clear to staff. And again, lack of training and engagement. We need to focus on creating an environment where incident reporting is encouraged and attended to. One of the key ways to do this is to create a culture of quality improvement. And I'm going to leave you with this thought. Peter Drucker, a famous strategist, said that culture eats strategy for breakfast. So we can have as many policies and procedures in place as we like and do as many audits as we like. But if staff are not invested and included in the quality process, and if it's not something that we do by day, it will become a huge challenge. It is not easy to create a culture of quality and safety. It's quite complex and can take time, but there are lots of steps that can happen for our profession and for our local hospitals and clinical sites that can create this culture where our patients are kept safe. In conclusion, clinical audit is a powerful tool in the quest for optimal justification in radiology, and an incident reporting culture should be promoted, but with clarity around what constitutes a near miss or an incident regarding justification. Here are some key references. Thank you so much for listening and for your time, and please feel free to contact me at any point if you would like to discuss further, ask some questions, or perhaps do some work together on the justification process.
Hello, everybody. And thank you, Dr. Mary-Louise Ryan, for that very, very informative talk. Very much appreciate your time. And if there are any questions related to the talk, please do put them in the Q&A now, and we'll be able to talk about them in this final portion of the workshop. So while we're waiting to see if questions come in following on from the PowerPoint, I'd like to welcome all the panel members back this morning. Delighted to see you all on screen. And what we will do is maybe look at a couple of outstanding questions from cases 1 to 12. There were a couple. And some general questions, really. One comment that came in through the Q&A is related to metastases, and obviously there were a couple of cases with query metastases in the referral. And somebody has asked the question: PET-CT, would that not be the gold standard for looking for metastases? So I don't know if there's anybody on the panel who'd like to speak about.
If I jump in, Louise, someone said, is PET-CT best for case 12? Not as a frontline investigation. The availability of PET is limited even in high resource settings. The radiation burden from a single PET scan is considerably higher than that of a chest X-ray. And if you actually found that the posterior rib pain was due to consolidation and sort of paraneumonic effusion, a PET-CT would be inappropriate and is, I think, rarely indicated as a frontline investigation for anything.
Yeah, no. Thank you, Nick. Thank you for coming in on that one. I'm just going through the different questions. There's one general question that came in. What do the panel think of removing the term routine from our vocabulary and text? I don't know how you feel about that. Should we have routine?
Yeah, I think that's a really interesting question, and it was one of the things we saw, and I mentioned in my talk when we did some audits and we looked around like mobile and non-mobile radiography, and a lot of mobile chest radiography is almost like a feeling of being routine. If somebody is in intensive care, and some hospitals just do kind of a chest X-ray day as routine. It's actually a very important question. You know, imaging is a diagnostic test, and I don't genuinely believe personally that it should be just kind of routines and routines and routines. You know, that takes away from that justification. Everything should be considered within isolation. You know, each exam should be considered in isolation from each other, and that was something that very much came across when we look specifically at mobile chest X-rays, and there was this very localized feel around it. So I think that is a good point, that we should probably move away from it, but I suppose it does depend on the context as well. And we all use the word probably a bit differently, but certainly I don't believe imaging should be routine. It should be, you know, always justified and always classified quite specifically. Certainly that would be my thought.
Okay. No, that's great. Any other comments from the panel?
Yeah, sort of jumping in on that. I think some of the language is very sort of emotive and depends on which side of the equation you're looking at. There was a acute medicine consultant that was sort of teaching the trainee physicians and saying, to you, a routine post-take ward round is every single person's worst day of their life. So for you, seeing 20 patients, you know, someone with chest pain, someone with abdominal pain, someone with cellulitis, for medical professionals, including radiographers, that is Tuesday, Wednesday, Saturday, Monday. But for every single person you interact with or their family, it's potentially the worst day of their life. And that's how do we remind ourselves that there is nothing routine about this for a patient. Even someone who has multiple sequential imaging, even as an outpatient, so they're a bit more aware that they're having multiple imaging, coming back for a restaging of breast cancer, coming back to see if you've perforated, nothing is routine about it.
Okay. No, that's great. It's a very, very good point. A very important point. And we have another question coming in that's quite general, and it's one that is asked, we've heard it asked, I'm quite sure, at congresses. Is the radiation burden of a diagnostic text a priority, examination a priority, considering patients may be facing radiotherapy or chemotherapy? And I suppose that's aimed at, this is a justification workshop, and we've included diagnostic imaging and whether they're justified or not. I don't know if Shane would like to comment on that, or?
Of course, yeah. I suppose when it comes to justification, it's not just about radiation burden. We're talking about appropriateness of exams and resources, and for the health system in general, that we're giving the patient the best test or the right test at the right time. So it's not, of course, it's not all about radiation burden. And I understand the point. I think if we're stressing and concerned over a CT exam that might have 8 millisieverts, but then a patient is maybe having radiotherapy with 4 sieverts, there's a big difference there. And in fact, we can look at the other way and say, actually, that CT exam is going to better help with the radiation therapy if it's planning CT exactly, and it can actually fine tune it and make it a better outcomes hopefully for patients. So yeah, I suppose we do have to build in radiation to our consideration, but it's not the overriding one. It should be about what's the best test for this patient now to help them on their pathway.
Yeah, thank you, Shane.
To add to that, and forgive me, I think it's the ESR just brought out a paper there the other day. I could be wrong, it may not be the ESR, it could be the ACR, but that we shouldn't consider, you know, that radiation burden continuously in like continuously justifying examinations. You know, it's not necessarily related to justification as such, but that, you know, if it has to be done, it should be done. And it was just brought out there the last few days, I think, actually, to support that.
Yeah, I suppose on that topic, I suppose using the word burden itself implies this big danger associated with radiation, when in fact, when the exams are justified, we're doing it, it's a radiation benefit. We're doing radiation, using radiation for the benefit of the patient to help streamline pathways, expedite treatment and care.
As a matter As a matter of fact, Louise, linking on to what Marie-Louise and Shane were saying, justification is not just for modalities using ionizing radiation. In the session, we had MRI cases which do not make use of ionizing radiation, but they still need to be justified. So it's not just a question of radiation burden.
Yeah.
That's a very good point, Frank.
Very good point, yeah. I think the other thing to add to that point is that, you know, all our health systems are so stretched at the moment, and we're listening to it all the time in the media, and, you know, doing the right test is also, you know, it's also a financial piece and a workflow piece as well. And I know we're talking a lot about radiation and best imaging and about the clinical aspect of it, but there is also certainly a management and a best use of resources aspect of it as well. You know, having again worked in management, we can see that when we're doing kind of wrong tests or doing them just for the sake of doing them, you know, it becomes quite a financial burden. And we saw that in our audit that was in my presentation when we looked at on-call CT, which is very expensive from a manager's perspective. So on-call CT should be for the most urgent that can't wait till the next day. But we saw almost, I think it was 30% that could have waited. Till the next day or whatever. So, you know, it is a way of not just, justification is a way of not just looking at the clinical side of it, but I think the non-clinical aspect we can't forget either, because we're all very stretched and we're all frightened, I think, by it. So, you know, this is a time maybe to raise that as well.
Can I just add something? Because I think one reason why we first and foremost think of radiation is because the justification is a radiation protection principle, and that's why I think radiographers overemphasize this part of ensuring that we are giving the patient the right care. And it's about time that we highlight the other aspects of inappropriate imaging also, and don't focus so much on the radiation issues. That I think, especially for the professional radiographers, we tend to overemphasize radiation concerns.
I just mention one other point. We did an audit in Blackpool many years ago on portable chest radiography, and with PACS back then, you could actually determine if and when the images were actually reviewed. And to our horror, we found that at least 30% of those images were never reviewed by anyone. So I think when we took clinical audit, or when we go down the road of justification, we've got to be reassured that the images will be reviewed and reported on by somebody. So I think that's something that also needs to be taken into consideration.
And I think a good point has just been made. A question has come in that legislation requires a doctor or nurse to, but in some countries, a nurse to request X-rays, but there's no such protection for ultrasound and MR, and the non-ionizing. But as the discussion is going ahead this morning, to justify those is so important and have the ability. So whoever's referring, we need to have absolute confidence in, and etc. So it's just a point that's come in. I don't know if anybody else wants to comment on that point.
I will. I think we have to remember that these people who are referring in are non-medical referrers, and it doesn't matter what modality they're referring into, they still have to be referring in appropriately. And as Frank said, MR is not a modality that uses radiation, and justification is intrinsically linked to radiation, but we still have to use the justification principles to almost protect our modalities to not be inundated with inappropriate requests. We've just spent a number of years trying to get approval for orthopedic nurse practitioners to refer for MR spine. We knew that they were writing the requests out, and we knew that they were just sticking it under the nose of a doctor to sign. We've eventually got that approval. So there has to be the governance around non-medical referrers into all the modalities. It just needs to mirror the non-medical referrers within the radiation modalities.
Yeah.
That's
a good point.
Yeah.
Sorry.
So I second that. So we
Frankie?
have non-medical referrers at UCH, which actually is for all imaging, be it nuclear medicine, which comes down to RSAC, or ultrasound or MRI. It's ensuring appropriate governance and use of resources. So any non-medical person wanting to reflect any imaging just comes through the same process.
Yeah.
Which legislation it falls under almost doesn't matter. The patient needs an appropriate test and it needs to be managed that way.
And also, Louise, justification for non-ionizing modalities, it doesn't mean that these don't carry their own risks as well. So we're focused on radiation, but there are other risks associated to other modalities. And the people out there might have a false impression that ultrasound is completely safe, MRI is completely safe, which is not true.
Okay. Yeah,
we're also probably not considering the issue of over-diagnosis and over-investigation.
Well.
When we're picking up more and more incidental findings and leading to different follow-ups and treatments and costs for everyone, and even worry for the patient.
Yeah.
I'm very aware that we're coming close to the end of our session at the moment. There are a couple of questions coming in and we will attempt to answer those, but we may not have time on air to answer them. Just one quick question about the clinical audit presentation, because obviously that was our last presentation. There has been a question, are the clinical audit guidelines that could be shared for radiographers, Marie-Louise?
Yeah, I mean, there's a few out there. A lot of them tend to be quite maybe radiologist focused, but there's a lot of good information that can be used within them, and some are very more radiographer practice focused. So Esperanto from the ESR was it's quite a recent one and gives some really good information. There's the Audit Live cookbook from RCR, which gives loads of samples of audits and audit tools that people actually can submit themselves as well. So that's really helpful. The ACR also have a lovely guideline as well. So there's quite a few. I know the Society of Radiographers in the UK also have a guideline as well. So there is quite a few. But you do need to take into account sometimes you have to adapt those for what works for yourself. Yeah, locally.
I actually put links for those into the chat box for anyone who wants to just click on them.
Will do.
No, I've done
it. Thank you.
Oh, you've done it. Okay.
Thank you, Shane. Thank you. I think on that, we are really coming to a close here. We've only a few minutes left for this workshop. We would like to ask the audience if you could give feedback as to whether you believe that a justification workshop at future congresses would be of value. We value your opinion on that. So if you could feedback to us, we'd appreciate it. But in closing this workshop, what I'd like to do is, firstly, I'd like to thank the ISRRT for supporting the delivery of the justification workshop. Thank you to the President, Donna Newman, and to Stuart Whitley, who's with us this morning. I'd also like to thank my co-chair, Dr. Frank Zarb, who chaired the first portion of the workshop, and all the panel members who've been with us this morning, and especially the audience as well, for you participating in the polls and participating in the Q&A. It's very much appreciated. We really hope that the discussion and provided information that's going to support our practice, your practice, and the practice of radiography overall. We really hope that you enjoy the ISRRT Congress, which is going to occur over the next 3 days. And we really wish you well and hope you keep safe wherever you are in the world. And thank you for your time and participation. Okay, thank you.
Baik Bapak Ibu, selamat malam. Demikian tadi acara workshop 1, Justification Workshop. Kemudian sebentar lagi pada pukul 19.30 WIB kita akan live kembali untuk menyaksikan pembukaan atau opening dari Isrrt World Congress Dublin 2021 akan dimulai pada pukul 19.30 WIB atau 20.30 WITA. Jadi nantikan acara selanjutnya live dari HSIT PP Pari. Selamat menyaksikan dan sampai jumpa lagi. Terima kasih Bapak Ibu. Terima kasih atas kebersamaannya. Saya akan end untuk live streaming sesi 1, workshop 1 dari mulai sore hari tadi pukul 15 hingga 18.30 WIB. Baik, sampai jumpa. Saya end of streaming. End streaming. Kemudian